The broadcast is now starting. All attendees are in listen-only mode.
Okay, Dr. Thakur, is all yours.
Thank you very much, Julia. Hi, good evening, everyone. Thanks for attending the webinar today. And today I'm going to talk about autoimmune epilepsy. Autoimmune epilepsy is a relatively recent entity in the world of epilepsy or epileptic disorders. And in the last 10 years, there has been a growing interest in the relationship between autoimmune disorders and epilepsy. There is growing evidence to suggest that autoimmunity might play a role in epileptic disorders. And there has shown refractory epilepsies with unclear etiologies. At least some of them might have an autoimmune etiology. So just a brief introduction about epilepsy. Epilepsy is defined as 2 episodes of unprovoked seizures. And seizures are abnormal discharges of electrical activity of the brain that results in transient loss of mental function or loss of motor and sensory functions. Epilepsy and seizures affect nearly 3 million Americans of all ages. Approximately 200,000 new cases of seizures and epilepsy occur every year. The lifetime likelihood of experiencing at least one epileptic seizure is about 9%. And the lifetime likelihood of being diagnosed with epilepsy is almost close to 3%. Now let's try to discuss about autoimmune disorders in general. What are autoimmune disorders? So autoimmune disorders occur when your body's immune system does not work the way it's supposed to, and it starts attacking and damaging your own body itself. The function of body's immune system is a protective function. It acts as a policeman of your body where it protects against disease and infections. So in a healthy person, the immune system will recognize foreign organisms like infectious organisms, bacteria, viruses as foreign invaders, and develops a protective mechanism by producing protective proteins called antibodies to attack them. However, in some people, the immune system does not function properly, and it misidentifies the body's own healthy tissues as foreign and attacks them, leading to autoimmune diseases. The next slide would give you a pictorial description of it. So as you can see on the top, which is a normal immune response, when antigens invade your body, antibodies are produced, and the antibodies attack the invading antigens, destroy the antigens, and they protect you, and the person is healthy. In an autoimmune disease, the immune system by mistake identifies body's own proteins as antigens, and these are called self-antigens, and thus it forms antibodies against the self-antigens and attacks the self-antigens, leading to damage or inflammation of body's tissues. Different parts can be affected depending on the type of autoimmune disorder, and in general, autoimmune disorders can affect any part of the body. As you can see in the picture, brain can be affected, eyes are affected, GI system is affected, thyroid is one of the most common organs that's affected, blood vessels can be affected, pancreas, livers, any part of the body can be affected. And there are more than 80 different types of autoimmune disorders that are recognized. The prevalence of autoimmune disorders currently is thought to be 50 million cases. The most common autoimmune disorders are Hashimoto's thyroiditis, Graves' disease, type 1 diabetes, multiple sclerosis, systemic lupus erythematosus, rheumatoid arthritis, polymyositis, scleroderma, and Sjögren syndrome. Now let's try to discuss further the link between epilepsy and autoimmune disorders. So 30% of patients with epilepsy have drug-resistant epilepsy. And in most of these cases, the etiology or the cause remains unclear. Now there is growing evidence that at least in some of these epilepsies, autoimmune mechanisms might have a role. And supporting this argument is the identification of serum autoantibodies in epilepsy patients. One cohort study reports 14% of epilepsy patients with refractory seizures had serum antibodies. And experimental data shows that these antibodies can be epileptogenic, meaning they can produce seizures. And then the evidence that some of these epilepsy syndromes respond to immunomodulatory therapies. Autoimmune epilepsy can be classified into two types. Autoimmune epilepsy that is associated with systemic autoimmune disorders, and autoimmune epilepsy that is not associated with systemic autoimmune disorders. This can be further classified into paraneoplastic and non-paraneoplastic. As you can see, paraneoplastic means it's associated with a distant tumor, and non-paraneoplastic is not associated with tumor. Autoimmune epilepsies with systemic autoimmune disorders. So systemic autoimmune disorders can affect multiple organ systems, including the brain. And when they affect the brain, seizures can be a presenting system. The possible mechanisms are when the autoimmune disorders affect the blood vessels, they increase the risk to have clots, which can cause strokes or can form microemboli in the brain, causing damage to the brain, which can produce seizures. And similarly, vasculitis, again, it damages the blood vessels and can produce seizures when it affects the brain. Antineuronal antibodies are the antibodies which directly affect the neuron. And autoimmune disorders causally affect multiple organ systems. They can cause multiple metabolic disorders, which can cause metabolic abnormalities, for example, hyponatremia or hyponatremia, hypoglycemia, low glucose, which indirectly can cause seizures. In addition to that, the treatments that are used for some of the systemic autoimmune disorders, mainly the immunomodulatory medications, can increase the risk of seizures by themselves. Or sometimes it can be pure coincidence. Now, we do not have extensive data regarding the prevalence of autoimmune epilepsy or the percentage of patients where we can attribute the epilepsy to autoimmune causes. There has been a recently published study in March of this year, which provides some evidence at a level of population regarding the autoimmune cause of epilepsy. So in this study, they used insurance claims data of more than 2.5 million subscribers of a national health insurance carrier, and they assessed the relationship between epilepsy and the 12 commonly known autoimmune diseases. So what they found was 17.5% of patients with epilepsy had an autoimmune cause in that study population. I'm sorry, not an autoimmune cause, I correct myself. 17.5% of patients had an autoimmune disease in that study population. And in their analysis, they found that the risk of epilepsy was increased by 4-fold in a patient with an autoimmune disease and was especially high in children. And the risk was consistently observed across all the 12 autoimmune diseases. And the other point that is usually considered when autoimmune disorders are considered is sometimes autoimmune drugs can also cause autoimmune disorders by itself. However, in this study, they found that anti-epileptic drugs did not show a considerable link to cause immunological side effects, because 70% of the study population already had an autoimmune disease before they were exposed to anti-epileptic medications for at least 2 years before the diagnosis of autoimmune disease. So there was no relationship between an epilepsy patient being on an anti-epileptic medication that could have caused autoimmune disease. So this slide gives you a percentage of epilepsy patients in different autoimmune disorders. Antiphospholipid syndrome, 3.2% of the patients had epilepsy. The risk of having epilepsy is 9 times higher compared to normal population. Systemic lupus erythematosus, 2.5% of the patients had epilepsy. Type 1 diabetes, 1.8%. Celiac disease, 1.5%. Hashimoto's thyroiditis, 0.8%. Psoriasis, 0.7%. Now let's talk a little bit about each of the most common autoimmune disorders. Systemic lupus erythematosus, or SLE. So lupus erythematosus involves central nervous system in 25 to 75% of cases. And actually seizures can occur as a presenting symptom, and seizures is one of the 11 primary diagnostic criteria for SLE. And seizures can occur at the onset or also during disease flare-ups. The most common seizures are generalized tonic-clonic seizures in about 75% of patients, but simple and complex partial seizures can also occur. SLE is also associated with antiphospholipid antibodies, which are prothrombotic, and they are found to be elevated in most of the lupus patients with seizures or epilepsy. Sjögren syndrome is characterized by inflammation and destruction of the salivary glands and the lacrimal glands, which are the tear glands, and it can also be associated with inflammation of the blood vessels and other organs involved. Neurological disorders occur in about 25% of patients. Seizures occur in 3% of patients, and most of the seizures can either be generalized or partial. Sarcoidosis is a granulomatous condition, and it's a non-caseating granuloma. And neurological symptoms or neurosarcoidosis occurs in about 5% of cases, and it usually occurs in the first years of presentation. Seizures can occur in 10% of neurosarcoidosis. The most common presentation of neurosarcoidosis is actually cranial neuropathies because of the involvement of the basal meninges, and patients might have nerve palsies like facial nerve palsies or other nerve palsies, and when it involves the cortical areas, then you have seizures. Celiac disease is a disease, autoimmune disease that's related to small intestine, and it is provoked by exposure to a gluten protein called gliadin, which is present in wheat and other grains. The prevalence of epilepsy, according to different studies or series, is 1% to 5%. The cause of seizures is entirely not known, but there could be multiple reasons for it, probably gluten neurotoxicity or pyridoxine and folate deficiency. Because it's an intestinal disorder, there could be malabsorption of vitamins. Hashimoto's encephalopathy is a rare, but it's a life-threatening condition, and that's the reason it's important. It's often underdiagnosed and is characterized by relapsing and remitting encephalopathic symptoms. It is associated with anti-thyroid antibodies, particularly anti-thyroid peroxidase antibody. Most of the patients are clinically euthyroid, meaning they have a normal thyroid function. The usual presenting symptoms are acute onset of confusional state, seizures, and stroke-like episodes. Or occasionally there could be a slow presentation of chronic cognitive decline, dementia, and other psychiatric disorders like agitation, depression, and psychosis. And seizures affect 66% of the patients. This is an overall summary of the different systemic autoimmune disorders. I'll just leave the slide on for a minute so that we can go through different systemic lupus erythematosus. We talked about it. Sjögren syndrome, we talked about it. Wegener's granulomatosis, it's mostly common in the Middle Eastern countries. It's caused by granulomatous vasculitis of the blood vessels, and it mainly causes peripheral neuropathy, but seizures can occur in 3% of the cases. Behçet syndrome, 2 to 2.5% of 2.2 to 5% of patients can have seizures. Now coming to other type of autoimmune epilepsy, which is not associated with systemic disorders, this can be subclassified into paraneoplastic, which is associated with tumors, and non-paraneoplastic, which is not associated with tumors. Paraneoplastic and non-paraneoplastic can be further subclassified as limbic encephalitis or multifocal encephalitis. Limbic encephalitis is inflammation of the limbic regions of the brain, which is in the temporal lobe, and the multifocal encephalitis can involve different regions of the brain. But limbic encephalitis is very focal and mainly involves the limbic temporal regions of the brain. In general, paraneoplastic neurological syndromes, they cover a wide range of diseases and involve both the central nervous and the peripheral nervous system. Limbic encephalitis, paraneoplastic encephalomyelitis involve the central nervous system. Paraneoplastic cerebellar degeneration again involves the central nervous system and involves the cerebellum. Brainstem encephalitis involves the brainstem. Oxomyoclonus syndrome. Limbic encephalitis is very closely associated with seizures. It can have an acute or subacute onset and can present with recent memory disorder presentation. Patients also have seizures. They also present with psychiatric manifestations. Sometimes extralimbic central nervous system areas might also be involved. And studies have shown that paraneoplastic limbic encephalitis, a tumor is detected in at least 60% of the patients. So limbic encephalitis can be classified as paraneoplastic, where a tumor is identified, or non-paraneoplastic. A European database shows a tumor was detected in 51 cases of limbic encephalitis, and in 40 patients, the tumor was identified after the onset of the neurological symptoms. The most common tumors are small cell lung cancer, testicular cancer, breast cancer, and limbic encephalitis has specific MRI findings. On MRI, we see increased theta signal activity in 70 to 80% of cases. If a PET scan is done, it might detect presence of hypermetabolism even before the development of MRI abnormalities. And usually the PET signals can be modified with the clinical course of the disease, while the MRI abnormalities remain unchanged. Limbic encephalitis can be further classified by the antibodies. The antibodies can be divided into paraneoplastic antibodies, which are the classical onconeuronal antibodies. They are typically directed against the intracellular antigens of the neuron. And the other antibodies are the surface antigen antibodies. Most of the surface antigen antibodies are non-paraneoplastic, but some of them can be paraneoplastic. The common paraneoplastic antibodies associated with limbic encephalitis are anti-HU antibody, which is associated with small cell lung cancer. Anti-MA2 antibody is associated with testicular cancer. Anti-CV2/CRMP5 antibody is associated with small cell lung cancer, thymoma, and testicular cancer. Anti-RI antibody is associated with small cell lung cancer and breast cancer. Anti-amphiphysin antibody is associated with lung cancer. So overall, most of the antibodies are associated with lung cancers and testicular cancer or breast cancer. Surface antigen antibodies, as discussed before, most of these antibodies are not paraneoplastic, meaning they are not associated with a tumor. Anti-VGKC antibodies is one of them. It's not usually not associated with a tumor in majority of cases, but tumors have been detected in about 20 to 30% of cases. The most common presentation is autonomic dysfunction, sleep disorders, neuromyotonia, and low sodium. And this condition responds very well to immunomodulatory treatments. The other non-paraneoplastic antibody is anti-GAD antibody. Anti-NMDA receptor antibody is associated with ovarian tumors. Usually patients present with flu-like episodes followed by severe psychiatric symptoms and catatonic state, and of course seizures. This once again gives an overall summary of the different onconeuronal antibodies. Q antibody psychiatric manifestations are some short-term memory loss, confusion, presence of seizures. MRI will show mesial temporal lobe changes and some non-mesial temporal lobe manifestations too. They respond well to immunomodulation, steroids, and treatment of the tumor itself. Anti-MA2 antibody, again, presents with psychiatric symptoms, causes seizures, and it also involves the brainstem and can cause hypothalamic dysfunction leading to excessive sleepiness. MRI will show changes in the mesial temporal lobe, and patients respond or improve after the tumor is removed. Anti-CRMP antibodies present with psychiatric symptoms, seizures, and neuropathy, and other abnormal movement disorders like chorea, where they have abnormal movements. The treatment is unclear. Similarly to anti-amphiphysin antibody, they can present with psychiatric symptoms, seizures, and myoclonus. The response to treatment is unclear. Now, coming to management of autoimmune epilepsy. This is a very growing field of management. At this point, the data we have is limited. So for diagnosis, it requires a high level of suspicion as the clinical presentations are very heterogeneous, as you can see, and they're very non-specific. So these are some of the recommendations from different study groups. It is recommended to investigate further to find an autoimmune etiology if there is an unusually high seizure frequency, if the seizures have a multifocal presentations, meaning the patients have different types of seizures, which lead the physician to suspect that the seizures are coming from seizures are arising from different areas of the brain. If there are associated neurological or psychiatric symptoms, drug-resistant epilepsy, if there is a personal or family history of autoimmunity, and if there is a recent history or past history of tumors. So if any of the patients who present with any of these features, it is recommended that the possibility of autoimmune diseases needs to be investigated. For diagnosis, serological and CSF testing are very valuable in establishing the diagnosis. Selective autoantibody testing is not advised because no single neural antibody is definitely associated with seizures. And added to the fact is failure to detect the antibody does not exclude the diagnosis of epilepsy because there could be several antibodies that are still not diagnosed, for which the testing is not currently available. MRI is very helpful, but the initial MRIs can sometimes be normal. So serial MRIs are very helpful and recommended when the suspicion is high. PET scans might play a role, and however, the cost effectiveness of the benefit has to be evaluated further. What's unique about the PET scans in autoimmune encephalitis is usually PET scans in epilepsy patients show focal hypometabolism. However, a cohort study at the Mayo Clinic showed that patients with autoimmune epilepsy had a focal hypermetabolism. So for diagnosis, nearly half of the cases have normal and radiological findings in a Mayo Clinic study. That means autoimmune epilepsies are underrecognized. And so this has to be really kept in mind. At this point, the studies we have are limited. Failure to detect a neural antibody does not exclude the diagnosis when other clinical clues exist. Treatment strategies. Paraneoplastic, encephalitis associated with autoimmune epilepsy, patients benefit with tumor removal, and immunomodulatory therapies. Non-paraneoplastic autoimmune epilepsy or systemic autoimmune disorders associated with epilepsy benefit from immunomodulatory therapies. This is a study that was published last year by Mayo Clinic regarding immunomodulatory therapies that were used in patients with autoimmune epilepsy. So a trial of 6 to 12 weeks of immunotherapy, which involved IV steroids, which is methylprednisone, or intravenous immunoglobulin, given daily for 3 days and then weekly. 22 of the 27 patients showed a positive response. And the study showed that early treatment was associated with a favorable outcome. And the study also recommends long-term immunosuppressive treatment in patients who have responded favorably to the initial immunotherapy. But despite this, relapses might still occur. So the challenges ahead are the clinical spectrum of autoimmune epilepsy is still unknown. Still, there are too many questions unanswered. We do not know the natural history of autoimmune epilepsy. Selection criteria for patients with epilepsy who will most likely benefit from an autoimmune evaluation is still not clear. The timing and duration of immunotherapy and trials are not clear. Clinical experience suggests that immunotherapy should be used in combination with anti-epileptic medications to optimize seizure control. So lots of challenges ahead, but this is a recent growing entity with increasing evidence and increasing interest in the field of epilepsy as the refractory seizures which are not treated with anti-epileptic, which cannot be treated with anti-epileptic medications, and patients who are not surgical candidates, possibly immunomodulatory therapies might be one of the treatment options. Thank you very much for listening to this presentation, and if you have any questions, please do email us, and hopefully I would be able to answer them. Thank you very much.